Professoressa Gabriella Pravettoni. You are the Professor of Cognitive Psychology in the University of Milan, and you've been working a long time on personalized medicine and patient empowerment. And we work with eCancer with you in a couple of FP7 projects. I've seen lots of definitions of P-medicine, and there was a Nature paper on P4, P1, 2, 3, 4, to which you responded, what about P5? And what is P5?
Okay. So there were more than 140 definitions of personalized medicine, and no one was on patient person. So I just replied to Nature was a special issue on personalized medicine that for sure we have to concentrate on patient and on person, and not just on the genomics or the molecular biology or things that are, of course, precision and perfect things to work on and very important for science, but not enough for patient. The idea that there is at the base on that is that we concentrate very often on the promise of science that is good, but it's not the reality of the patient. That's the problem we have. So I just tried to give an immediate answer to the patient, to the person, not to forget the person, even if I recognize the great job of science and necessary great job of science to work for the patient.
The patient can't do much with a promise.
Yeah,
right?
That's the point.
That's the bottom line. That's one. Now, there's lots of stuff at this ESMO meeting about patient empowerment. I don't actually think that I would put any of what's going on here on the term patient empowerment, because it's key to personalized medicine.
Yeah.
Well, what is your definition of patient empowerment?
Yeah, my definition of patient empowerment is that we have to empower, so to help the patient, to help the person to have something better immediately. As we told before, we don't live on something that will come or will happen, but what we have now. So, for example, in one of the projects we are working together, you know that we are trying to build a platform for the patient where the patient has some tools that can immediately use and have a response, follow-up, to help on one side the doctor to better understand the patient, to better communicate with the patient, and on the side of the patient to better explain what he has, what he, she is, even on the personality profile, to do the better choice and to realize together between the doctor and the patient what they can do.
So you're saying that the patient should have something to do with the choice of treatment?
Yes, of course. Yes, of course. I think that when we talk on personalize, we say the right treatment to the right patient, or in my view is the right treatment to the right person that has a specific profile of personality. So, for example, to better explain is that if I'm working with a patient that has a risky profile, personality profile with a high risk, means that I could easily involve in clinical trials. But if I'm working with a person that has an anxiety trait of personality, a person that is depressed, I cannot involve in an experimental clinical trial with a high risk, because for that person the right answer is to work now with something that is recognized. Otherwise, when she talk with all the others, patients and persons, or go for a second opinion, and the answer is different from the one the first doctor suggested, the problem is that he feels more anxious. Yeah. So it's not right for him.
Now, cognitive psychology is unquestionably now come into its own and is recognized in mainstream medicine, no question. However, mainstream doctors like me don't actually understand how you do it. So how do you do this kind of research? I mean, how do you physically find out about 5 kinds of personality, and how do you give patients information that they can use in decision making?
Okay, but the idea basically is the fact that we work a bit using questionnaires, using fMRI if we are doing a neurocognitive psycho research, but there are many ways, but even online, for example, we use some tools, as you know, or virtual reality for other patients. It depends, of course, on the scientific base of the research, but the idea is to help people to have the right mindset, so concentrates on language, on culture of that patient, on memory, on attention, all the cognitive abilities that that patient has.
Good. And you do that by questionnaire and by probing through, and you can do that online. The patient can sit in a waiting room and answer the questions, and then...
If we are talking on the personality questionnaire, yes, of course.
Okay. And then how do we get information to patients in a more intelligible, personalized way?
Oh, for example, we build a questionnaire that is called ALGA, where we try to identify the personality profile of a person, of a patient, and to give the right suggestion, the right keywords to the doctor to help in a better way that patient. And what we can do is just asking to the patient to answer on an iPad to some questions, and we have results that are 5 types of personalities, and of course to the doctor what arrives are just a few words, clear words, in which they could help in a better way the patient.
You talked about culture being important, and you are doing some of this work in different languages.
Yes, yes, for sure. For example, ALGA, of course, started from Italy because we realized the questionnaire, but then was immediately translated in English, French, German, Spanish, and Latino America. That is different from the Spanish. I mean, what we really understood, and in Japanese, for example. And this is very important because we needed to not only to translate, but to understand that somewhere the culture is different and even the words are different. So to better understand something that is very keen to us, we can't use the Spanish for the Venezuelans, for example. So we need to use the right words to reach the patient.
Gabriella, thank you. That was very clear, and now I understand a little bit more about it.
Oh, thank you.
Look forward to sharing the results with you in a year's time.
Okay. Many thanks.